Good morning, everyone. This is Erin from the Department of Medicaid. It's not quite 9:30 and the waiting room is still clearing out, so we'll give it just a moment before we get started.
Is everybody in from the waiting room, Erin?
I was just trying to unmute myself. Still have a flood of people coming in, so if you'd like to give it just a sec. I was searching. Sure. You came in with a large group and I didn't see you. You snuck in on me.
Well, and I had the wrong name. I was traveling incognito with my Nicola Foreman name, so I had to change that and get my video on. So yes, Kent, you're right. Just trying to sneak around.
The waiting room is officially well, we got one more, but we're pretty much cleared if you'd like to go ahead and begin.
Okay. Good morning, everyone. Some of us have had late nights watching the action in the General Assembly. So hopefully everybody can join who needs to be with us. We'll call the meeting to order. The MAC meeting for March 28th, 2024. And Mackenzie Wallace, if you're on, would you call the roll, please?
Yes, ma'am. Good morning, everyone. Apologies. I think I missed our last meeting. It's been quite a busy session, so my apologies. Yes,
no problem. Thank you, Mackenzie.
Of course. Elizabeth Parton.
She's going to be a few minutes or an hour late. She texted me, but she's coming.
All right. Nina Eisner.
I'm here.
Susan Stewart.
I'm here.
Dr. Roberts.
I'm here.
Heather Smith. Dr. Bobrovsky.
Here.
Dr. Compton.
Here.
Dr. Mueller.
He is on spring break this week.
Lucky. Dr. Gupta. John Dadds.
I think Ashima is on. I saw her thing. She may be muted.
Okay.
And Heather Smith is currently joining as well. I think you just called her name.
Okay, great.
Thank you.
Let's try again. John Dadds. Dr. Hannah,
Here.
Barry Martin, Kent Gilbert,
I'm here.
Mackenzie Wallace, I am here.
Hmm.
Anissa Franklin, Dr. Schuster, you are here.
Here,
Brian Proctor, Peggy Rourke, Eric Wright, and Commissioner Lee.
I am here.
great.
Mackenzie, I see Peggy Rourke logged in. She might not have heard you. She just logged in for the
Okay,
record.
great. All right, anyone who has just joined that maybe I missed? Oh, Dr. Gupta, okay. Dr. Gupta is here. She says she cannot hear though. She's wondering if she's still in the waiting.
Huh.
I'm sorry, who is that you said can't hear?
Dr.
Dr.
Gupta,
Gupta.
Ashima Gupta.
No, we see her, so I'm not sure. There's no one in the waiting room currently.
And we also have that from a pharmacist with Anthem who says they can't hear. So it must be at their end. Right, Aaron? It's
That would
everybody
be
else.
my guess. Can everyone hear me? I can hear everyone.
Yeah.
So I'm not sure.
Should we ask them to log out and log back in and see if that corrects them?
That
Okay.
might be a good idea, Commissioner. I know Zoom has, like Dr. Schuster knows, we were breaking up a couple weeks during behavioral health, and Zoom and I have just not been good friends. So
I'm not sure how to signal them to log off and log back in.
I just sent them a
can't hear
message
us.
in the chat. I just sent them a message in
Okay,
chat because
thank you.
they're looking at the chat.
Yeah. All right. Well, let's go on. We have a quorum, Mackenzie. Do we?
Yes, ma'am.
Okay. Let's go on and approve the minutes of the January 25th meeting that were sent out by the court reporter. Is there a motion to approve?
This is
Yeah.
Nina Eisner. I'll make that motion.
Thank
I'll
you.
second it.
Is that Barth? Who seconded, please?
Yeah.
Yeah. All right. Any additions, corrections, revisions? All those in favor of approving the minutes signify by saying aye.
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 Any opposed? And any abstaining? Thank you. Our perennial question, although there may be a slightly different answer this time, what's the status of Anthem MCO, Commissioner?
Well, it does still remain the same answer. All legal avenues have not entirely been exhausted, so the legal proceedings are not final as of today. So we may have a different update at the next MAC meeting, but as of right now, no change.
Although there was a court ruling
Mhm.
between the
Yes.
last meeting and this meeting that was not in their favor. So the question is whether they appeal and so forth.
Correct. So nothing,
Okay.
nothing final yet.
Yeah, thank you. We had some questions because the MCOs at our last meeting mentioned a 2% withhold to meet HEDIS quality measures. And we're wondering if that's a change, excuse me, in the MCO Medicaid contract for 2024.
Yes, that was a change in the contract in 2024. And I believe later on in the meeting, Angie Parker is going to give a little bit of an update and explain a little bit about how all that works and some of the parameters around that and the specific quality measures.
Yes, I think we got some materials about that. So we look forward to that later in the meeting. Thank you.
Mhm.
And then just going back, because the telehealth keeps coming up as a question, do any of the MAC members have any questions on telehealth? Any differences between the federal and state flexibilities?
Well, this is mine. I'm sorry. I have a question still about whether or not PHP can be provided via telehealth.
Yeah, hi, Nana, we have, and I think, someone else has reached out to me with that same question, and we have have been communicating with CMS and have not heard back from them, but I will follow up after the MAC meeting with CMS related to that question.
Thank you.
Thank you, Commissioner. I know that that's been a question that the hospitals and others providing partial hospitalization for those who don't know PHP. Any other questions that you had, Dinah? Because I know that.
No, that's all. Thank you.
Okay. Kathy Adams with the Children's Alliance has her hand up. Kathy? Oh. Ashima, you have your hand up, Dr. Gupta? Oh, now we can't hear you.
Kathy says she can't unmute.
Yeah, do you have the, Aaron, do you have people muted who are not on the Mac?
No, they should have the ability to unmute themselves.
Kathy, if you can unmute, would you put your question in the chat, please?
I just got it. Was able to unmute. I apologize. This is Kathy Adams with the Children's Alliance, and we just received a clarification from Behavioral Health Department of Developmental and Disabilities, DBH-DID, regarding supervision performed via telehealth for CSAs, TSM, and peer supports, because their regulation requires it to be in person. And so they are going, I think it's face-to-face, but their definition might be different. So they intend to amend their regulation, but did give us the green light to go ahead and provide supervision for CSAs, TCM, and peer supports by telehealth until they can get their regulation amended. And I just wanted to make sure that it wouldn't be a problem with Medicaid. The Medicaid regs refer specifically to the behavioral health regulation number, that they have to follow the requirements of that regulation. Is that on your radar?
Thanks for bringing that to our attention. I'll defer to my behavioral health specialist to see if it's on their radar. If not, what I would recommend definitely in the event of a future audit, to keep that documentation from BDID on file, so that you have that documentation from them stating that they are amending their records and they have given you approval to continue those services via telehealth. And then I will ask if my behavioral health team that's on the phone, if they have anything, or on the call, if they have anything else to add to that, or if there's anything on their radar, or maybe even if Jonathan is on the call related to the regulation.
Hello, Commissioner Lee. Jonathan Scott, Chief Legislative and Regulatory Officer, DMS. That's correct. We defer to the licensing boards. So if you have documentation from the licensing boards that it is acceptable, then you just need to keep that documentation, and it would be consistent with 3170.
In this case, Jonathan, it's not a licensure board. It's actually the Department for Behavioral Health. Would that also qualify?
If our reg, Jonathan, references the behavioral health reg.
Yeah, but we do also defer to other state and federal law. So you could use that justification as well, to use the behavioral health reg. Would be my interpretation.
Okay.
Thank you.
In the meantime, before they get their reg changed, what you're suggesting, Commissioner, is that the letter would suffice to move to that or to be able to do supervision via telehealth.
Yes, and I definitely.
Not inconsistent with the Medicaid reg, and then they have the permission and the letter from DBH-DID.
Correct. And again, I would just, make sure to maintain a copy of that letter on file for any future questions or audits that may come up around those services.
That sounds
Kathy,
wonderful. Thank you all so much.
Can you repeat the groups that you're going to be able to do supervision via tele? You said Peer Support and who else?
Community Support Associates and Targeted Case Managers.
Thank you.
And this is awesome. So thank you all so much.
Thank you for bringing it to our attention. I'm glad we had the telehealth is so important. And I think we probably just need to keep it on there in case as things come along. And until we get the PHP resolved, we'll just keep that on there. Dr. Gupta, we're still up in old business. I think you had a question about where we were in the agenda. Did you have a question about telehealth? Was there anything in the chat from her?
There is. I'm trying to scroll.
Okay.
Sorry. She
She
says
did-
in regards, oh, sorry, Commissioner.
Oh, that's okay, Aaron. Yeah, she wanted us to repeat whether the 2% withhold was a change in the MCO contract, and yes, that was a change in the MCO contract.
Oh, okay. And yes, Leslie Hoffman from the behavioral health team says that they will coordinate with DBH on the
So
issue.
it's just not hanging out there, Dr. Schuster. We'll connect with them.
Okay, great. It's confusing to us all if we think one state agency saying one thing and one state agency saying another thing, and the providers get caught. We don't want that to happen. So, Commissioner, the MCOs are going to have these same HEDIS measures.
Commissioner, this is Angie Parker. Would you like me to go through a PowerPoint that I have regarding the value-based payment program? Or wait.
It's on down. I mean, Dr. Schuster, it's up to you. We do have on 5D the hospital and quality measures. So if you would like Angie to go through her presentation right now, we can go back up to some of the others under 5.
Why don't we have you do that, Angie, since we've been talking about the quality measures, and obviously, so it really doesn't matter whether we do it under 4B or 5D. If you don't mind doing that, that would be great.
Not a problem.
Thank you.
Now to find it. I've got too many windows. Here we go. All right. So I had some questions regarding the MCO value-based payment program. And this value-based payment program went into effect, which it started contract year 2024. And yes, there were some contract changes specifically that addressed this. The value-based payment program is, we worked with our actuary to determine this and what would be the best measures for the state of Kentucky and where we want to incentivize our MCOs for potential payment strategies to achieve positive outcomes. Some of the within the program development and strategy and goals were to reward the plans that perform well and penalize those that perform poorly. We want to use this program to improve Kentucky's national state health ranking. As you may have heard in other meetings with the commissioner, we're now at 41%. So, we're trying to get that even under, even better. So that's part of what this program is about as well. Include performance targets that are realistic and achievable. incentivize quality outcomes, be operationally straightforward to oversee and manage, and hopefully ease administrative burdens for our providers to participate. So how was it designed? As you mentioned, we do have a 2% capitation withhold from the total contract value per MCO. There are 6 core measures plus a bonus pool for eligible MCOs. They are to achieve at least 3% or 4% improvement from measurement year 22 HEDIS measures to earn this withhold. They must earn withhold on 4 core measures and maintain performance on all core measures to be eligible for the bonus pool. And it's pass-fail. So what are the measures? The core measures include preventive services for children, postpartum care, immunizations, and we're looking at the chronic condition and diabetes. We are also for social needs screening for, it's a report only for 2024 because it's a new HEDIS measure. Also for immunization for adolescents, the IMA Combo 2, we are allowing just IMA Combo 1 for 2024, and they will, but the HPV reporting only for 2024 to allow for more education for providers and members on the importance of getting the HPV vaccination. So if the MCOs have to meet at least 4 of these, 3% or 4%, depending on the percentile of the HEDIS measure, in order to be eligible for the bonus pool. And they have to meet these are the measures that are they will be eligible for to receive additional monies for. So metabolic monitoring for children and adolescents on antipsychotics, follow-up after emergency department visits for alcohol and drug dependence within 7 days of an ED visit, weight assessment and counseling for nutrition and physical activity for children and adolescents, and breast cancer screening. So that is it in a nutshell. Very high level on what the measures are and what the capitation, what we're withholding, and how we are administering that in start of 2024 based on 2022 HEDIS measures. So they have to get at least 3% or 4% improvement in 2024.
Auntie, I have a couple of questions. Would you go back to the core? They have to have 4 out of those core measures.
Yes, ma'am.
But 2 of them are report only, so they qualify or they meet that core measure if they have a report?
Well, for the immunization for adolescents, it's actually IMA Combo 1 that they would be graded on. IMA Combo 2 includes HPV. That section is report only, but they do have to meet the IMA Combo 1. They have to improve upon that.
Okay, and then on the social needs, which is brand new,
yes,
they have to demonstrate that they.
Right. That we will be establishing the baseline for this one in 2024 because there was not one in 2022 for this particular.
Okay. All right, and then if you go to the next one on, I cannot tell you how happy I am to see the metabolic monitoring. You know, we have way too many kids, particularly foster kids, who are on antipsychotic medications. I know that U of L has reported on that on a number of occasions. So I'm thrilled to see that that's one of the things. I actually think it ought to be a core measure because it really ought to be done for every kid in that age group that's on antipsychotic medication. Because as you all know, FDA does not approve medications for kids that young. So I applaud that. Thank you. Are there any questions from any of the MAC members? And you'll share these with Erin so she can send them out to us afterwards, the slides. Angie?
Absolutely. Yes, ma'am.
This is Nina. I have a question. I'm surprised there are no measures for psychiatric hospitals. one of the things they watch very closely is the HEDIS measure for ambulatory follow-up within 7 and 30 days post-acute hospitalization.
Mhm.
And that's something that's really important. And sometimes, if there's not sufficient geo access or, you all monitor, of course, missed appointments. So maybe in future years, they can add that. Y'all can consider adding that to one of the measures.
Sure, we can look at that. And just so everybody understands how we came up with these measures, we looked at HEDIS for measurement year 2022, all of the measures. And where the MCO's measures were lacking or less than the 25 percentile and knew that there was a lot of room for improvement, I would have to go and look at that specific measure you're talking about to see if maybe they're performing well on that. But certainly we can, this will be an ongoing thing, evaluating each year on if we need to make any adjustments to this, but thank you.
Thank you.
Certainly look at that. I see Dr. Bobrowski has his hand raised.
Just a question on, and I don't know a whole lot about all this other than some of the things you see in the news, but that metabolic monitoring in children and adults on the antipsychotics, does that monitoring also involve or include the hormone blockers that some of the doctors are using in our teenagers?
I don't know the answer to that question, Dr. Bobrowski. I'd have to go look and see. I'm thinking maybe not, but I'll have to go back to look at what the specifics are underneath that.
Okay, thank you.
I'll follow up with that.
Garth, if you're talking about puberty blockers, they're no longer allowed in Kentucky for children under 18 unless they have a specific metabolic. In other words, they're not used for gender transition after the passage of Senate Bill 150 last session.
That's right. I remember that now. Thank you.
Yeah.
Yes.
Unfortunately, so those kids are not getting treatment for gender dysphoria here in Kentucky. Just a reminder about that. Any other questions that any MAC members have? All right, hearing none. Thank you very much, Angie. That's very helpful. I appreciate your doing that. Let's move on to updates. And we want to start by congratulating Commissioner Lee on being named the board chair of the National Association of Medicaid Directors. That's a big deal. And so we're very proud of you, Commissioner Lee, and very proud of Kentucky for being recognized as in a leadership position. I understand that Dr. Stack holds a similar position among the public health commissioners as well. So congratulations.
Thank you so much. My tenure, I guess, or my new role with NAMID will start on April 1st. So I'm really excited to be able to work with all the Medicaid directors across the country and help put forth the Medicaid issues, concerns, and priorities, put them forth at a national level and meet on a routine basis with CMS. And while I will be representing the entire country with the Medicaid program, we can always put forth Kentucky's priorities too. So it does give us a little bit of an opportunity. And I am very excited to start that new role. And it will not impact my role as commissioner in the Department for Medicaid Services. I'm still going to be here. It's just a little bit more I guess a little bit more responsibility that will help us, I think, at the national level. So very excited for that opportunity. And thank you so much, Dr. Schuster.
Well, and more contact with CMS is always helpful, I think, to the state. So, and I know you all work hard to have a good working relationship with CMS, but it puts you in a great position for that. So we're grateful for that and for your leadership. Let's talk about unwinding Medicaid, any changes in approach and flexibilities.
I think we have
typically,
yeah, we have the
Senior Commissioner Veronica Judy Cecil.
Hi, good morning, everyone. This is Veronica Judy Cecil, Senior Deputy Commissioner. And Dr. Schuster, I wasn't sure if you wanted me to get into any numbers today. I'm prepared to do that if you want, but we just held our stakeholder meeting last Thursday, and that presentation, recorded presentation and slides are up on our website. I think the only thing that really has changed other than the numbers is that we have decided to redistribute about 39,000 individuals into May as a way for us to manage workload. Our April, our March and April numbers are fairly high in the number of renewals. For March, there were 116,000, and for April, it was 103,000 individuals going through a renewal. So we did want to distribute some of our folks into May, which was approved by CMS for us to do that. So you will see still individuals going through their first renewal following the public health emergency in May.
I think it's helpful to see some of those numbers. We had that at the BH-TAC, and I think it's that new group that you're going back and doing the look back on is particularly interesting. Veronica, if you could share your slides, that would be great.
Yeah, happy to.
Thank you.
Erin, I'm gonna kick you off. Okay. All right. Let me just don't get too sick. Oh, one thing I would like to mention. So we did move the flexibilities related to the 1915C home and community-based waivers into amended waivers. And we just got notice a day or two ago that all of the waivers have been approved by CMS. So all the amendments that we put into those waivers, which are out on our website, are now part and permanent as part of the approval of those waivers. So did want to mention that. We do have a really good website related specifically to the Appendix K and those waivers.
Yeah, that's fine. Yeah, you were doing good. I just thought
Okay. If you're not speaking, please mute. I just want to point out to people, Veronica, that the budget that was just passed by the Senate has a significantly increased number of placements or slots. I hate slots because it sounds like widgets, and we know these are people, but a significantly expanded number of people who can go into the HCB, Michelle P, and SCL waivers. So having those approved by CMS and having all the flexibilities in Appendix K is really helpful. So thank you for that.
You're so welcome. Our team, Medicaid for the waivers, they're amazing and have done a lot of work on those efforts. So what you're looking at is new to folks who might have seen our presentation in January or the typical presentation that we give. But just to explain what's going on, it might look a little overwhelming. And I'm not going to go through all these numbers, but what you're seeing is that in October last year, CMS instructed Medicaid state agencies to start reporting an updated monthly report that provides information about any pending cases following 90 days after the renewal month that have been processed. So on the left side here, you see our original CMS monthly report. So these are from May to November. What we reported in that normal CMS monthly report. All these are still on our website. And in that, you see the pending list. We'll take May for an example. You see we had 2,698 pending cases when we reported that for our May renewals. A pending case means that the member has responded to a notice or provided us information, and the state had not yet taken action on that when the renewal date passed. So on May 31st, we had 2,698 cases pending, and they got extended as part of that until the state could process those pending cases. So in the middle there is that 90-day processing period. So again, following the 90 days from each renewal month, In May, we were able to process 2,659 of those pending cases. And so on the right side, you're going to see our updated numbers as a result of that processing. So you'll see that our approval numbers and our termination numbers have moved slightly as a result, so that we can put someone in the correct column. And we do still have some pending. That's not too unusual for Medicaid. And the reason for that generally sometimes is that it's a complex case, but these folks should still be covered as that pending case continues. So that's what you're going to see now up on our website, is the report that was required by CMS initially, and then the updated report for each month showing that 90-day period. We do have to wait until the 90-day period exhausts, and then the report's due the 15th of the month following that. So that's why we have May through November so far. And we'll provide this to the MAC members, and it'll get posted on the MAC website. But this is out right now as a result of the March stakeholder meeting. So just looking at the most current numbers since our last MAC meeting, that would be for January and February. You see there the individual number for renewals for that month, the Medicaid approvals for the month, and then the terminations, still some pending. And the extended are those folks that were using the flexibility. They can have an additional up to 3 months if they're long-term care or 1915C waiver members, and they've not yet returned that notice. We can extend them up to 3 months past their renewal date. That's not the same thing as the 90-day reinstatement, which I'll talk about, but this is actually us being able to keep the person covered for an additional up to 3 months if they've not returned that packet, so we can not procedurally terminate them. And then for everyone else, they get a month. So if somebody hasn't responded by the end of February, then we can give them additional month to return that information. We do conduct a lot of additional outreach during that time, both the state and the managed care organizations, outreach to those members to try to get them to respond to that notice. The reinstatement on the far right there is if somebody after they're terminated and within 90 days following that, they provide the information we needed because they didn't respond, then we can determine them eligible based on that information. Then we can reinstate them back to their renewal date, 90 days, as if there was no gap in their coverage. So we still try to outreach to folks to, and to providers or anyone who comes across a Medicaid member who was just terminated for not responding, that they can still, within this 90 days, still try to work through their renewal. So those are the numbers. Happy to take any questions.
Thank you so much, Veronica. Are there any questions from any of the MAC members? Excuse me. Just a reminder to all of you, particularly those who represent providers, that we really do have an obligation to keep reminding people to respond to these requests for information. And I know, Veronica, that you've got on your website some easily downloadable flyers or poster kinds of things that people can post in their offices and clinics, and they're available in both English and Spanish, as I remember.
That's correct. Yep.
Yeah. So
yeah, I think the other thing, Dr. Schuster, is though we've really increased our outreach as a result of the public health emergency unwinding, we are looking at keeping the nudges and the outreach as we move into the new normal of enrollment and eligibility processing. And so we hope that all of our stakeholders, all those folks out there supporting our members, the families, the advocates, the providers, that we stay, I think vigilant in reminding folks about the fact that they have to go through an annual renewal. So we hope that all those communication continue to be used following the public health emergency unwinding.
That's a great point, and I see that Beth Fisher has just put a link in the chat for anyone who needs those materials. Obviously, not just the MAC members, but all the people that are attending this meeting. It's just so important that we keep people enrolled who are eligible and that we check their eligibility. So we appreciate it. And I know this has been your baby from the beginning, Veronica. So we appreciate the updated numbers as well.
You're welcome.
Commissioner, I'm sorry. We congratulated you and then immediately went to specific reports. Let's go back and see if you have some general comments or updates that you want to give from the department.
Yeah, I think I'd like to take this opportunity, Dr. Schuster, to coming on the heels of the quality update that we just heard. I'd like to take this opportunity, if I could, to talk about America's Health Rankings. In 2014, Kentucky was ranked 47th, and we have moved up in the rankings to 41st, as Angie had pointed out in her presentation, which I think is a wonderful thing. But see if I can share my screen. I would like to see if I can figure out how to.
1 second, Commissioner. I got to
Okay.
make you a co-host.
Okay,
Sorry.
thank you. Thanks, Erin.
You should be good to go now.
Okay, let's see. Can y'all see my screen now with the America's?
It says you've started screen sharing, but yeah.
Yeah, you can see that. Okay, this is Kentucky. This is America's Health Rankings, and they have every single state listed and where they rank. As you can see, Kentucky is 41st, and we can see that our strengths are definitely a low prevalence of excessive drinking, which we think is really good. We have a high prevalence of colorectal cancer screenings, and we have a high supply of primary care providers, which was just a little bit surprising to me, but that's some of our strengths. Our challenges, of course, are high prevalence of multiple chronic conditions, high occupational fatality rate. I don't know that this group can do anything about that, and high prevalence of insufficient sleep. We've moved we've had an increase in homicides. We've also had an increase in diabetes, and we've had a decrease in physical inactivity. And these health rankings are for the entire state. They're not just for Medicaid. However, we think that the 1.5 million members that we serve, if Medicaid could be a leader in improving the healthcare status of those individuals, then we could also improve the health status of this state overall. So we think that Medicaid has a really good position to kind of make a difference in health policy and be a leader. And I've highlighted some of the areas where I think that we could concentrate. For example, our adverse childhood experiences, we rank 46th. So all of these areas that I've just highlighted a few, I think, definitely room for improvement. I think Dr. Brabowski will agree. Dental providers number per 100,000, we rank 32nd in the nation. How can we get a few more dental providers to focus on oral health? Our preventive clinical services, again, we rank 42nd on the number of adults who have visited a dentist. The HPV vaccine, we saw that in our quality measures that we're have put in place for the managed care organizations. We're hoping to make a difference there. Preventable hospital discharges, exercise, physical activity, team burn, smoking. Here's a really big one, is smoking and the percentage of adults. And just recently this month, the Center for Medicare and Medicaid Services released a guidance related to what states can do, specifically Medicaid agencies, in order to reduce smoking in the state. So what I want to do is I'm going to send a link to Erin. I'll give that to her to send out to the TAC. And what I would like for you to do, I request is your assistance, is looking at this America's Health Rankings, looking at something that you think that we can make a difference in. And let's look at the policies, the Medicaid policies around those certain measures, or what sort of information that we need to see where, what data do you need from our claims information that we could start looking at to make a difference in some of these measures. I mean, drug deaths, we are 47th, but we know that, we've got a pretty extensive behavioral health delivery system. But what else can we do in order to bring that number into an alignment with at least on the national level, or increase it for our members? Premature deaths, again, physical health, we know, frequent physical distress, low birth weight babies, how can we improve that? And it's not just us, and it's not just the MAC, it's any of our partners across the state, and particularly our sister agencies, our Department for Public Health, our Department for Community-Based Services, Behavioral Health, and our Department for Aging and Independent Living, happy to form any kind of work group to work on any of these measures. Obesity, you see that we're 37th. And again, what can Medicaid do? What policies can we look at? Are there educational materials that we could develop specifically for our members? And if so, what does that look like? So I just again would like the MAC to look at all of these measures, look at the report, and kind of help Medicaid figure out, what we can do, because the report itself basically states that, that this is a sort of a roadmap. It says that they urge policymakers and leaders to use this report as a snapshot of the post-pandemic health landscape, and improving health outcomes for all needs to remain at the forefront of the nation's priorities. And I could not agree more with that. And I think that we have an opportunity given our quality measures, not only with their MCOs, but with their hospitals and their directed payments. We have an opportunity to further increase Kentucky's health rankings. And I just would ask for your future collaboration, and would be remiss if I didn't thank you for everything that you've done on the MAC and the tax to help us get to 41st, because we didn't do that alone. This was a collaboration, and we just want to make sure that we're using this information in a way that guides us on our roadmap and improving the health status of all of those we serve.
Thank you so much. I think this is an excellent project for the MAC, and I hope that the link will link us to your version of this, where you have highlighted some of the ones that stick out to you. That would be great. And Aaron can share that, and then I'll get with the MAC members and see, and the TAC chairs actually, and see what kinds of recommendations we might be able to come up with, or projects to look at some of these things.
And again, we're happy to pull in other partners and form some little work groups if you think that that's necessary.
Yeah. That's great. Are there any questions from any of the MAC members about the health rankings, or the commissioner's thoughts about this?
I'd just like to underscore the importance of this, and I want to thank the commissioner for raising this. I think that, those who are in my circles know that I'm on a constant drumbeat that, Kentucky doesn't have to be in the lower 10 of every ranking. We have shown some dramatic ability to improve. And I think that, I think some of the next steps that might be, Sheila, maybe you, or perhaps Commissioner Lee, might be helpful for us to identify where can we have the greatest impact with limited resources. As we know, some of these things could be vastly improved with improved budgeting, which we are at great pains to get, but at limited access to. If there are ways that we can target specific things that are within the departments, the MAC's ability to influence, I think that, it would be a great project for us to sort of target something and see those needles move, and to then, God willing, use that to say, look, this is the reason we need more funding, and here's how we can apply that effectively. But I want to thank you so much for raising this issue, because I think I am unsatisfied deeply that we are 41st. Not thrilled that we went from 47th. But I don't think we should not rest on any laurels. I'm really glad we got better, but we ain't there. And I think anything we can do to get better, particularly around outcomes for children, preventative care, all the things you highlighted are very, very important.
I
Thank
couldn't
you,
agree
Ted.
more.
Yeah. Any other, Garth, did you have your hand up?
Yes, please.
Yes.
Wanted to thank Commissioner Lee for bringing these up. And I know you mentioned one of them was the drug use, and it was I was watching a news channel the other day, and they had the president of Mexico on there, and in a way he made a stunning remark that the United States drug problem was not his problem. And in a way, I guess I hate to admit it, but in a way he's correct. But it's like, why do Americans seek these drugs? And you all know, once you get on one, you want to get your body becomes immune to it, and you need more or a stronger dose. And I know a few years back I did almost like a term paper for the Kentucky Dental Association on narcotics, opioids, and prescription writing and all that. But it's kind of like, those are things like Commissioner Lee says, like, we need to look at how even other states are brainstorming within this group of how to decrease the demand in Kentucky. I know there used to be a DARE program through the school systems that they had I think it's 5th or maybe 6th graders. But to be honest, I don't know the final, the results, or if there's even a way to test the results of those programs. But you're right. I mean, knowledge is what we've got to get out there. But when so many children are raised in a drug using home or environment, that's all they know. But I just wanted to emphasize that what Commissioner Lee was saying on drug use, and I agree with Kent on some of the things that he was saying. So thank you. Just a comment.
Thank you, Garth. And we're going to talk later about expanding healthcare access in schools, both on the behavioral health side and the physical health side. And I think that we've got to concentrate our efforts on prevention and education there. I think you're right. Unfortunately, I don't think the DARE program yielded the results that we had hoped that it was going to. And the Just Say No, part of that was easy to say, but didn't. But I think we can come up with some things, and there are some things in the works, I think. Any other, Dr. Gupta is saying this is good information, Commissioner. Any other questions or comments from any of the MAC members? Okay, well, thank you. I think that's very stimulating and certainly gives us some excellent guidance, Commissioner, and something to work from, which is really helpful. I think, Leslie, you're probably up on the mobile crisis development since our last report, please.
Yes, and I would just say we're busy both internally and externally right now with our stakeholders and providers. Lots of work is going on, and we probably have anywhere from 7 to 10 meetings a week in various different areas. So I think I told you before, we've met with the CMHCs. We started with CMHCs and the CCBHCs, as the CMHCs are the safety net. We started there. We have also started to reach out to RSUs and BHSOs. We actually have meetings today with additional providers. We've reached out to 4 possible behavioral health crisis transport providers as well, and trying to build capacity there. And we'll be reaching out to more BHSOs in the near future, and also any interested providers that can meet the criteria to be a mobile crisis provider, meet that fidelity. We did complete some policy guidance. We sent it out related to the mobile crisis services and what the ASO will be responsible for. And I think those went out to all folks that were interested in possible contracts at the time. So those will continue. We have ongoing regular weekly meetings with the MCOs and continue to work on the contract. Our CCCR grant option, which is our community co-response. I know you all, every time I'm on here, I just like, that is going so well. We've been so pleased with the folks that have stepped up to the plate, and several of them have even met, like they had to meet milestones within their grant opportunities, and several have already exceeded our expectation on meeting their milestones. We did an in-person, if you saw that on social media just recently. It was a hybrid, but we had a lot of folks there. Very exciting times, and we've also met with each one of those individually. So that's pretty much my conversations about mobile right now. More to come very soon, Dr. Schuster.
And what's the target implementation or go live date?
So our tentative target date was June. That may change just based on us waiting to see what's going on with the budget, and I won't speak much more to that right now.
Okay. I did look at the budget, House Bill 6 that was passed by the Senate, 36-1, I guess, last night. And there was no restoration of the mobile crisis funds that had been taken out. So continuing concern that we have there. You had mentioned at the BH TAC, Leslie, the policy guidelines. Could you send me a copy of those, please?
Yes,
I'm not a contractor.
Sorry, I didn't mean to cut you off. They actually sent those out. I thought they were going individually, but they actually sent those out with the contract. So I will get a copy of that for you, Dr. Schuster.
Yeah, I'd like to share that with the BH
Absolutely.
TAC and obviously with anybody on the MAC that's particularly interested. This is a major overhaul of mobile crisis around behavioral health issues to try to get treatment, not just the 988 call line, but actual transportation to treatment if necessary at the time of crisis. So any questions from anybody on the MAC? And we'll keep, yes.
This is Nina. I just have a question from our partners with Medicaid. Is there any update on the BHSO AODE rate increases? The last one was April 1st of last year. I think y'all were working on them. I didn't know if anything had been finalized.
So Lisa or Commissioner Lee, correct me if I'm wrong, is that something that Victoria was working on and that she will bring back to the behavioral health TAC, I think, in May?
Yeah, we'll follow up on that, Nina.
Oh, thanks.
And we'll keep this item on the MAC agenda, Leslie, because obviously there will be some updates.
Dr. Schuster, would you mind if I mentioned the rate situation where I called you the other day?
Yeah, why don't you do that?
I'm sure folks have got questions about that. So on the behavioral health fee schedule that we got posted and sent to the MCOs, we did find an error. It was totally human error. It's on the H0002. I think that rate is around 52.57 maybe. It will have an MEI, which is the Medicare Economic Index added, which I think this year was around 4.6, and the new rate will be 65.45. So the MCOs have already been notified of that. I've already requested for it to be reposted with the correction on the website. So there was not supposed to be any decreases. There was 46 or more increases. So no decreases. So we'll get that one corrected if anybody's asked about that one, Dr. Schuster.
Yes, thank you. And I proactively reached out to the CMHCs and some of our big providers to let them know that. So I appreciate that. And appreciate the fact that there were no decreases in any of the behavioral health. I think you mentioned that some of the Medicare rates had actually gone down, but they did not, the Medicaid rates have not gone down. And there have been
a couple I think went down, and we ended up keeping the 23 rate. So
yeah,
so there was no decrease for this time.
That's really good news. We appreciate that. And Angie, you're back on again, please. You had sent out some materials on hospital and university quality measures that we're interested in learning a little bit more about.
Yes, I believe, yes, Angie Parker, Director of Quality and Population Health. I believe Aaron sent what the preprint looked like as far as what the quality measures were for 2024. We are actually working on 2025 and getting ready to submit those. As you may or may not know, this is an annual thing. We review and update measures annually and have to submit it to CMS for their review and approval. I do have another little PowerPoint that kind of shows this information. And as you know, as we continue to discuss about the quality of healthcare and what Commissioner Lee just provided, it is very exciting to me to hear everybody's excitement on how to work together to improve the quality of healthcare, not just within our Medicaid, but within the state. So I will pull this up again, or another one.
Me just a second. Angie, Aaron had to step away for a second, and I'm trying to stop her share, so.
Can you see mine?
Yes.
Okay. So what I'm going to be showing you is what the UK U of L directed payment measures are, what the hospital rate improvement program measures are, and then also the value-based payment program, which with the MCOs, and all in one little spot. And as you know, we're trying to work to align all these measures so that we can all be working towards the same goals. As you can see with UK U of L, there are, the well child visits, which were on the value-based purchasing program. What the commissioner talked about, how our obesity is, we're very high on the health index, postpartum depression screening, SDOH, chronic conditions, tobacco use, all of these measures that UK and U of L with their directed payment program are focusing on. And then the hospital rate improvement program, it's more directed for inpatient hospital with the catheter assisted UTIs, C. diff, sepsis screening, all cause readmissions, concurrent e-prescribing, opioid education, admission screening, hours of restraint, hours of seclusion, and rehab discharge, and also social determinants of health, which is not on this list, but they were developing programs for 2023 in which they will be measured on in 2024. And then we just went over the value-based purchasing measures and how UK U of L and the hospital rate improvement overlap. They both do the 30-day all cause and then the opioids. Because UK U of L has the clinic, outpatient clinic, that's where a lot of their focus is on, and that does help correspond with our value-based purchasing program. A lot of the same measures, as you'll see. And that is all I have on this little presentation.
Okay. Can you go back to the very first slide that had UK U of L?
Yes, ma'am.
I'm really glad to see the emphasis on screenings for depression in different age groups, postpartum, but also ages 12 to 17, because we know that is a time of great angst for our pre-adolescents and adolescents. And then it looks like, Angie, that fourth one is for adults, screening for clinical depression if it doesn't have an age thing.
Yes,
and a plan would be for all adult patients. Is that right?
Yes, ma'am. Yes.
Yeah, okay. So good, I'm glad to see that. Are there any questions or comments from any of the MAC members? This makes more sense than what I was trying to work my way through these tables, these preprints that came out. And I was like, what is
I know
it?
those could be, this is very high level again. It doesn't go into the detail of the preprints, but I thought this might be simpler to.
Yeah,
so we are looking to align our quality measures within all of our programs, with, and to Dr. Gilbert, improving 41. We don't want to stop at 41,
Right.
we want to move that needle. We are within the Division of Quality and Population Health. We are looking at those the health rankings and how we compare to the other states and seeing what they're doing. We just recently completed a comparison to the number 1 and 2. Of course, it's going to be a challenge to get down to that, but we're also going to be looking at surrounding states. Number 1 was Massachusetts, I believe, or maybe they were second, and New Hampshire. So, those are the Northeast kind of, but they're not on the West side. So we are looking to see what kind of programs the other states are doing and how potentially we can also initiate that here.
This may be a question more for the commissioner, but as you look at those health rankings, Commissioner, if you look at southern states, where is Kentucky? Because the southern states are always poorer in general health and in funding, as Kent pointed out.
Yeah, the least healthy states are Alabama, Oklahoma, Arkansas, Mississippi, and Louisiana. So all of those southern states, we rank 41st. So we're a little bit better than some of our neighbors, but the bottom 5 are definitely those southern states.
Well, we've always, and it's probably not very nice, but we've always said thank God for Mississippi in most comparisons. But so it is, I think that's interesting, Angie, that you all are reaching out to look at what other states, and obviously 1 and 2 seem way ahead of us, but there may be some lessons to be learned by from that middle tier, the ones that are around the, I don't know, 25th to 35th or something like that. Would be nice to get into that tier next in our rankings. Any other questions for Angie? And again, you'll share that PowerPoint with Erin, please.
Yes, absolutely.
Yeah, thank you. Thank you very much. And then something that's near and dear to my heart as the expanding healthcare access in schools. And I'm not sure, Commissioner, who's reporting on that.
I think Erica is on the phone.
Erica's on. Good.
And if Erica's not prepared, I can talk about it. So I'm not sure if Erica is still on, but I can start out talking about, as you all know, in 2020, early in 2020, or maybe in 2018, 2019, Kentucky did a state plan. We completed a state plan amendment that allowed us to provide school-based services, expanded access and care. It was under the free care rule. We don't really like to call it the free care rule, but basically before this rule came out, CMS said that state Medicaid agencies could not pay for services in schools if the schools provided that service free to the population, and they could not just bill Medicaid for the service. Well, then they reversed that and said, okay, you can bill schools, you can bill Medicaid. So we had to get a state plan in place, and we did. We got a state plan approved by CMS that allows us to provide services outside of the individualized education plan. So prior to this change, Medicaid could only pay for services that were developed and in a child's individualized education plan. So now Medicaid can expand services to any service that a school has personnel able to bill. So a school, for example, could bill for a well child check or for speech therapy for a child who does not have a developed IEP. So there was a huge work group that was created, and then COVID hit. And so COVID took precedence over all of our expanding health access in schools. So we have taken this project back up. We did a survey, because the first thing we want to do is get a lay of the landscape, if you will, in our schools. We have some schools that are not billing services and through the expanded care. And however, they do have a relationship with some of their community clinics to provide services or to set up schools in the clinic. So we're trying to get a lay of the land to see what Medicaid can do to help facilitate those services in schools, because we do believe that that is definitely a location where our children are. We can focus on primary and preventive care. And so we have also embarked upon some work groups. For example, we have through the Annie Casey Foundation, there is a children's behavioral health policy lab. Medicaid is participating in that with their Department for Behavioral Health, in addition to our Department for Juvenile Justice. We also have a National Governors Association's behavioral health learning group that we are in collaboration with Kentucky Department for Education, and the Lieutenant Governor's Office is heavily involved in that. As well as we just submitted a CMS grant application for school-based services. If awarded, we would be able to use funding to further expand care in schools to children and help schools come up to speed, for example, on billing and that sort of stuff. So this healthcare access in schools is a primary focus of ours. Erica Jones is leading up those initiatives, and we're very excited about some of the opportunities that we have to move forward. And if Erica, if she's on the phone, I don't know if she would like to add anything to that, or if
Hi,
I
this is
missed anything.
Erica. Commissioner Lee, I think you covered everything. Just wanted to add that we know of the 171 school districts, we have 166 that are participating in billing school-based services. Not all of those are using the expanded access. So that's what we're really pushing for, is to get more of those school districts to offer services to all of our Medicaid eligible students. And so that is our push now, as well as offering more mental health services. And when we did do that survey, we found that all models of delivery of school-based services are being used in Kentucky. We see that some school districts are being the billers of the services themselves. Others are contracting with outside providers and allowing those outside providers to bill. And then others are contracting with outside providers to do the services, but the school districts are the ones that are doing the billing for those as well. So we have several different models of delivery of services in the school setting.
And Erica, that's both physical health and behavioral health, right? That you're tracking?
That's correct. Yes.
Great. That's, and I think you're scheduled to present that data to the BHTAC in July at our meeting. So that's something that we may want to be sure that the Children's Health TAC is aware of, and perhaps that data could also be shared with them.
Yes, ma'am.
And I think, Commissioner, that you mentioned that the nursing TAC had asked for some of that same information. Is that right?
Yeah, I believe that is correct. And that, Erica, did the original request for the school-based services come from the nursing TAC?
I believe it did, yes. And so we can present that information to all of the interested TACs.
Yeah, I'd like to see the TACs coordinate more with each other. You know, there's obviously overlap. The primary care TAC would be interested in that information too. So we'll make that, that would be May the 1st, I think. We moved that meeting to 1 o'clock on May the 1st, but we'll let people know so that they can join in and get that report as well. I think this is really exciting. I think it also fits in with the presentation that the commissioner made on our health rankings, because I think we have to concentrate, at least preventively, on school kids. They're captive audiences in many ways, and we've got a better shot at heading off something than waiting until they're adults and then having to treat something that's developed. Any question? Kent, you had a question in the chat, and were you asking about the Annie Casey grant, how much it was for?
I was looking at that Shine grant actually to sort of see how much funding are we hoping to get for that.
Erica, I just put the title that we're calling it Kentucky Shine here in Kentucky. That was all I put in the chat. So, do you have the information? Is it 2.5?
Yes, ma'am. It's 2.5 million.
That'd be great. That'd be great support. And just to underscore, Sheila, I think, all the data keep showing that the more we can prevent the cost dollars that it saves Medicaid down the road is huge. So, and of course, outcomes for quality of life for those kiddos.
Right, right. All right. Any other questions or comments from any of the MAC members? All right. Well, let me thank all of the DMS folks who have presented and contributed to the discussion. It's so important to have the data, obviously, and for us to be coordinating our efforts. So we appreciate that. Let me turn to the TAC reports. And just Dr. Gupta, you're talking about a program with vaping, and vaping is a huge issue. Garth, it gets back to the, is that a gateway to drug use? And I hear from school counselors and school psychologists and school social workers about their concerns around increases in vaping, and even with very young kids. So that may be something we may particularly want to look at as we think about some ways to move forward on improving health status. Thank you for sharing that. Want to encourage again the TACs to work with other TACs and to let us know what data you're requesting from Medicaid so that we can share that data with other TACs that would be interested in it. So let's keep that in mind. And also to hear your recommendations. So we're starting at the front part of the alphabet. Behavioral health TAC met on March 14th. 6 of our 7 voting members were present. And very sadly, we announced that Mike Berry, a voting member of the TAC since its very beginning, had recently passed away. And we had a moment of silence in his honor. He was a great advocate for people with substance use disorders. And a replacement will be sought from that organization, people advocating recovery. We had representatives from DMS and from DBH-DID. All 6 MCOs were present, and a number of members of the behavioral health community. We had updates on the 1915I SPA, which is the one that would provide respite for families and supported housing, medication management for people with severe mental illness, and also a range of services for people with SUD. We had an update on the reentry TAC, reentry waiver. We had anticipated that we would have a report from the Office of Data Analysis on behavioral health rates, including their multi-state comparison study, but it was not quite ready. So we will have that at our May meeting. We had quite a lengthy discussion about behavioral health associates. These are bachelor level folks who would be allowed to do some clinical services as long as they are enrolled in a program working on their advanced degree in a behavioral health field. And Jonathan Scott was his usual helpful self. There was a lot of discussion about BHAs and also the MHA, mental health associates who have been utilized by the CMHCs for nearly 30 years. And they're going to be apparently displaced by the BHAs. And there is certainly some concern about that. Jonathan announced that there will be a meeting with the CMHCs following the BHTAC meeting, and also a meeting with the licensure boards and other interested stakeholders. Justin Derringer was not able to be at the meeting, and so we're delaying the report on the no-show dashboard. Alicia Clark stood in for Pam Smith. We always have an update on the 1915C waiver waiting list, which of course continue to grow and are a source of concern. I am pleased that the General Assembly has decided to look at this problem seriously and has funded many more placements in those waivers than we've ever had in a single budget session. Leslie gave a report on the mobile crisis services model, and Senior Deputy Commissioner Veronica Judy Cecil gave a Medicaid unwinding report. Erica Jones was on talking about the billing for student services, and I had intended to reach out to the Children's TAC to be sure that they could hear that report in July, but we will also reach out to the primary care TAC and to the nursing TAC and just generally let all the TACs know when that report is going to be given. We had a brief report for myself and Steve Shannon about what was going on in the legislature, and I see Karen Lenz has shared with us that there are a number of bills related to vaping that are making their way through the legislature, so there may be some hope there for some help from the legislature. We have no new recommendations to the MAC at this time. We then had a very active discussion initiated by Kathy Adams under new business about the significant number of prepayment audits being conducted by the MCOs and causing great concern among providers. And it was a far-ranging discussion. Veronica Cecil gave us some history that some of us were not aware of the audits and CMS's position and DMS's position and so forth. A number of other people at the meeting, a number of other agencies weighed in and said that they were concerned about this increased number of audits. So in our May meeting, we will have a presentation from DMS. We're preparing a list of some questions that we have that we would like to center the discussion around to better understand how these audits, what the purpose is, and what the guardrails are, both for the MCOs and for providers. In the meantime, it was suggested that providers use the provider complaint process to submit issues to DMS if they feel like the MCOs are acting in ways that are not appropriate. Our next meeting will be on Wednesday, May 2nd, I guess that is, from 1 to 3. And again, we had no recommendations. So that's the report from the Behavioral Health TAC. Next on the list is the Children's Health TAC. Is there a report or anybody there? All right, consumer rights and client needs, please.
Hi, good morning, everyone. I'm coming to you from the Capitol. I hope I have a good enough signal. And I apologize to the MAC members that I didn't submit a written report in advance as I normally do, but I will put that together for you and give you a verbal report today. Our consumer TAC last met on February 20th. We met remotely using Zoom and we had a quorum present. We discussed a number of the things that we typically monitor, but we had a rather long discussion about language access and other accessibility issues. For the past 2 or 3 meetings, we've been talking about a decision tree that would help to guide people when they are needing language access services. And we're thinking about it for 4 different populations: people who speak different languages, people who are deaf or hard of hearing, people with speech impairment, and people who are nonverbal. So the plan is that we are working with DMS on this decision tree, but we will also be making some more recommendations around these 4 populations at the upcoming meeting. And then another part of our discussion focused on the access to services form, which has been something in development for the past few months. DMS has been working on a form that Medicaid members could essentially use to report when they're unable to access a particular service, and that will help us to identify some of our network adequacy issues. So that's still in development, but I hope something that can be used soon. And then we had a discussion around the Medicaid membership survey that may have already been discussed this morning. We're excited that DMS is surveying members. This is the first time in my memory that members have been asked to share their input and their feedback on Medicaid services and their experience as an enrollee. And we think that this can be really beneficial for a number of reasons in terms of how the program is operated, future policy decisions. And we're excited to work with the cabinet on disseminating that, getting that out to as many people as possible and encouraging people to complete the survey. We also discussed a number of other things, but again, I didn't have the time because of the legislative session to put together a full report. We made 2 recommendations, and I'll just jump to those. The first recommendation is that DMS engage the consumer TAC on the development, dissemination, and evaluation of a Medicaid membership survey. And the second recommendation is that DMS create more video explainers and standardize the use of screen readers, closed captioning, and subtitles. And again, we'll come back with some more recommendations around language access after our next meeting, I suspect. We have an upcoming meeting scheduled for April 16th at 1:30 p.m. Eastern time, and that will be on Zoom. And I'm happy to answer any questions. Oh, I did actually want to bring up one more thing. And Dr. Schuster, you may have already mentioned this to the folks on the call today, but we are concerned about funding hole for the Medicaid budget over the biennium. It's $62 million that is currently cut from base funding. And I think now is the time for legislators to be hearing from Medicaid providers and other stakeholders that we need to fully fund Medicaid. We think that there may be a path through House Bill 1 to make sure that that money is included in the budget, but we just need to make sure that happens before the end of the session.
Thank you, Emily. I had not mentioned that that hole, which is significant, and it is in the base. So if people could reach out to their legislators and make sure that there is still House Bill 6 has already passed the Senate, but House Bill 1 has funding for weird assortment of things. I can't even describe it. So anyway, but there is another budget bill that's out there, so it could get fixed, and we definitely need for it to get fixed. I appreciate your work, Emily, on language access, because that's something I have on the agenda to be a MAC look at. So we'll be working with you on that. Thank you very much. And 2 recommendations we'll come back to. The dental tax, please.
Yes, thank you, Dr. Schuster. And the dental tax met in middle of February with it. We did have a quorum, and our next meeting is middle of May. We had some discussions, and some of these will include the issues that we have on our MAC that we bring up. I'll take them back to the TAC meetings that we have. One of the things I did want to bring to your attention, these are a new development that could affect each of us individually when you go to the dentist or in the groups that you represent. The medical physicists, the American Dental Association, the FDA, the Academy of Oral and Maxillofacial Radiologists have come out with a new recommendation that with the advances in X-ray technology and digital X-rays, the use of lead aprons is not needed now. So when you go to the dentist next time and they don't put that lead apron on you for your X-rays, it's just with the new technology of the machinery and stuff is hardly no radiation is exposed to the rest of your body. So the other thing we talked about was a dental loss ratio. And I'm like some of you all, you're on your local boards of health. I am the chairman of our board of health. And one of the things that was brought up, and Angie brought it up in her talks earlier this morning about how diabetes is affecting Kentucky. And some of the information was very important. And the rate of diabetes in Kentucky has doubled since 2000 to 2021. Kentucky is 13th highest in mortality rate in the nation. Diabetes treatment costs Kentucky $5.16 billion per year. So we do need to put all of our heads together and look at these situations and see what we can do. The other thing we talked about was our community health workers. And at the time, we did not have any recommendations from the dental TAC to the MAC. And I apologize again to you all that I didn't get this sent out to you to have this earlier on the reports, and sometimes life happens. So thank you.
Thank you, Garth, and appreciate the heads up about the lead aprons, because I would have asked, I'm sure. And also the emphasis on diabetes. So you have no recommendations from the dental TAC at this point, is that right?
That's right, yes.
Okay, thank you. EMS, please. No one there from EMS. They may be moving Aaron to quarterly meetings.
Dr. Schuster, yes, this is Kelly. Aaron had to step away for a minute. Yes, okay. They are moving to quarterly meetings, and they are not able to join the meeting today.
Okay, thank you, Kelly. I appreciate it. Health disparities, please.
Hey, this is Jordan Burke with the Health Disparities TAC. Yeah, we have not met since the last MAC meeting. Our next meeting is scheduled for April 17th. So we wouldn't have any new updates or recommendations at this time.
All right. Thank you very much, Dr. Burke. Home health care, please.
Hi, everyone. This is Evan Reinhardt from the Home Health TAC. We did meet on February 13th. We discussed electronic visit verification, some supplies issues, and other issues with MCEs. We received some updates from the MCOs and DMS, and we did not have any recommendations.
All right. Thank you very much, Evan. Hospital care.
This is Russ Ronaldo from the Hospital TAC. We met on February 27th. We had a quorum. We went through numerous items that's in the report. Many of those DMS requested examples so they could go through it and respond. We did have a discussion in depth about Change Healthcare and some of the impacts that we're having on the MCOs that would come over to the hospitals. DMS followed up with a pretty good Q&A from the MCOs on outstanding questions. We had no recommendations, and our next meeting is April 23rd.
Thank you very much, Russ. Appreciate that. The IDD TAC.
Good morning. This is Rick Chrisman. The TAC met on February the 6th. We had a quorum. We did a little bit of housekeeping discussion on filling up some of our vacancies. We also discussed an issue in terms of people, particularly in residential services, who have been involuntarily terminated, checking on their status and how difficult it is for them to find alternative providers. And so we're still gathering information on that. We spent some time talking about the waiting lists. I know, Dr. Schuster, that's an issue, a concern of yours. And Pam Smith and her group has put together an analysis of that shows how there are some of these individuals who are on the waiting list who are also getting services from other waivers. So that put that into perspective. And of course, we're also anxious to see with the General Assembly coming to a closure and its budget. And we know that there are monies in that the budget proposals to expand waiver services. So we're excited about that. Other than that, we had no recommendations.
Thank you, Chris. I was glad to see that the budget that passed the Senate is now over in the House has significant funding, $94 million over the biennium to increase salaries for those personal service care deliverers, which would be huge. And with the increased number of people coming into the waivers, having more people to provide the services is going to be very, very significant. I'd like to talk to you offline about the involuntary terminations from services, because I've had a discussion with Pam Smith, who is willing to look into that if we have more data. And that issue had been brought to me by someone else as well. And I didn't have the data. So I'll get with you separately, Chris.
Yes, I'm going to have to, I'm going to have to sign off, but we can get together later. And that's among our discussion is how we're going to gather that data and seeing. And so we're working on that. It's an important issue.
Yeah, thank you very much. Nursing homes. No one there? How about nursing services?
Yes, this is Lisa Lockhart. I'm the chair for the Nursing Services TAC. We do have a report, and I'd like to introduce Dr. DiPolito, please.
Thanks, Lisa, and thanks, Dr. Schuster. I just will summarize the nursing TAC recommendation. Our last meeting was February, and just a background about our recommendation is that in January of 2023, DMS responded to a MAC recommendation that essentially DMS was not going to prioritize adding CPMs as eligible providers for reimbursement for Medicaid services, and documented that it felt that it would create additional need for EMS transports if more home births were adopted in Kentucky. And just to summarize the nursing TAC stance on that statement, that we found no evidence that DMS is concerned that reimbursement for CPM services would strain the EMS system. So therefore, we would like to bring forward to the MAC again our strong recommendation that CPMs, certified professional midwives, be recognized as providers that will be eligible for reimbursement for Medicaid services, given that their licensure and regulation is from the Kentucky Board of Nursing. So in summary, we would put forth that recommendation again to the MAC.
All right, thank you very much, Dee, and helpful to have that background as well. So we'll put that in as a recommendation that we'll come back to vote on shortly. Thank you very much. Optometric care.
Yes, this is Steve Compton, a member of the Optometric TAC. We met on February 1st. We had a quorum. We had various discussions, generally around billing and coverage, and we generally get those worked out with the MCOs and subcontractors on those meetings. We have no recommendations at this time, and we meet again on May the 2nd.
All right, thank you very much, Steve. Appreciate it.
Thank you.
Steve Shannon, persons returning to society from incarceration, the longest name of any TAC.
Correct. This is Steve Shannon. We did meet. We met on March 14th, and we'll meet again on May 9th. Obviously, people are more than welcome to join us. We got an update on the reentry 1115 waiver. It's now called reentry. Maybe we can call ourselves the reentry TAC. Been submitted to CMS, questions back and forth. Initial set of questions were kind of standard initial questions, some clarification stuff. Do not anticipate any concerns yet. No timeline when it will be approved. You know, we've been waiting on this for since we started meeting as a real step forward. We appreciate the update. Good conversation again, trying to figure out how to cover hepatitis C for the full length of the dose, which I think is 84 days, and this is 60-day pre-release. So try to figure that one out. But people are talking and meeting on that to really address that issue. A good update from Medicaid. Thank you for Angela Sparrow for doing that. MCOs gave us updates. They kind of have the same dilemma we have. It's hard to provide an update on a service that doesn't really exist yet, but they're doing a lot of work now as they can on reentry. Not many referrals yet, but hopefully that changes. A lot of work on expungement, which is an important piece for individuals accessing jobs and some supported housing, get those things expunged. And we got a round robin update. Did a reentry lab. For some folks, it's an experience of reentry, what people go through. Typically, it takes about 2-3 hours, and you're given a list of factors, things you have to do, and you find out you can't get those things accomplished, and that maybe your parole is based on that. And the experiences, it's really hard when people coming back, not having sufficient support. And hopefully, this will address that as well. And we had no recommendations.
All right, thank you, Steve. And I know you all have been waiting, and hopefully that approval from CMS for the reentry waiver will come soon, and then you all will be very busy. Appreciate it.
Look forward to it.
Pharmacy TAC, please.
Yes, the pharmacy TAC did not have a report, and they will be meeting on April the 3rd.
All right, thank you very much. Physician services. Oh, ASHME's, we did not meet, but we are curious on the progress of the physicians. I can't read it all. Physician fee schedule. Is there anybody from Medicaid that can respond to that question?
Yes, we do have that report ready, and we hope to get that out to them at the first of next week, but we do have all of the information. We're preparing it to be submitted to the TAC. So we do have it. It is ready. We will be getting it to them within the next few days.
Wonderful. There's your answer, Dr. Gupta. All right. Thank you very much, Commissioner. Primary care.
Good morning, I'm Stephanie Moore. I'm representing the Primary Care TAC. We met on February 22nd and had several updates from Senior Deputy Commissioner Cecil, covering topics such as redetermination, the quality measures. Also, RAC reconciliation continues to be an evolving process for primary care providers in the states. We had some discussion there, and specifically some of the system updates in development. We also talked about the mobile crisis model and some potential gaps for primary care providers that have integrated outpatient behavioral health, and making sure that there's a response when patients in our clinics need additional level of service. We did not have any recommendations for the MAC, and we meet again on June 27th.
All right, thank you very much, Stephanie. And last but not least, therapy services.
Yes, thank you. This is Dale Lynn. And the therapy TAC met on March 12th, and we did have a quorum. We don't have anything to report to the MAC, other than I want to say we're very, very happy that the Medicaid has written a policy update that will not require the physician's signature on a plan of care to get an authorization, which is a big relief to the therapy group plus physicians. And we meet again on May 14th. Thank you.
All right, thank you very much, Dale. So I need a motion to accept the TAC recommendations. I believe there were 2 recommendations from Consumer Rights and Client Needs, and 1 recommendation from the Nursing Services TAC. And could I have a motion from a member of the MAC?
So moved.
And who's that, please?
Kent Gilbert.
Kent, thank you very much. And a second?
Robert, second. I'll second it.
I'm sorry. Who was it?
Peggy Rowart.
Yeah, Peggy, thank you very much. So the motion has been made and seconded to accept those TAC recommendations and send them on to DMS. All in favor signify by saying aye.
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 And any opposed, like sign, and any abstaining. Thank you very much, and thank you to those who were present, and we appreciate obviously the work of the TACs. Very important to all work from our various vantage points to improve health here in Kentucky. Next is Cheryl Hanna, and I've forgotten what MCAFS stands for. I apologize.
Well, good morning, Dr. Schuster. This is
Dr.
Richard
Schuster.
Flackler, and I see that Cheryl was on the agenda, but I'm the IS lead for the Medicaid Claims Administration and Financial Solution Project for the department.
Okay, so it's Medicaid, say that again, claims
Medicaid Claims Administration
administration.
and Financial Solution. And I do have a presentation that we did on the 14th of March for the wrap that we would like to present here as well, if that's okay.
That would be great. Thank you very much. Can he share his screen? Yeah, okay.
Okay, can everyone see my screen?
Yes, thank you.
Okay, once again, good morning, everyone. Really appreciate the time with you this morning. This is a presentation that we did a couple of weeks ago for the MCAFS project. You're going to be hearing a lot about this, and that is the Medicaid Claims Administration and Financial Solution. A fact sheet that I would like to, just touch base with you on is that the cabinet or the department is replacing its Medicaid management information system that's been around since 2007. It was known as the Interchange system. Gainwell was the vendor who was maintaining that system since 2007. And interestingly, Gainwell is the vendor that will be maintaining the MCAFS system. It's a very large system. The MCAFS project is going to interface with over 17 Medicaid related modules. There is information that I can provide. I won't go into all of those there, but I'm sure you can imagine. It is a change for the Commonwealth. We are leveraging a software as a service, or commonly known as a SaaS solution. And what that really means is that it lives in the cloud. Okay, we're accessing it online. Whereas the other solution, the legacy, what we're calling Interchange, that exists today, was a custom design solution that did not exist in the cloud. This is also a commercial off-the-shelf, what is known as COTS. Sorry about all the acronyms, but it is a COTS-based solution. And this is important. Once again, this solution from Gainwell has been marketed, stood up in several other states, Ohio, West Virginia. They've just gotten a contract to stand it up in Washington, D.C., and obviously Kentucky is one of the states as well. The solution is Medicaid information technology, what we call MITA, architecture compliant. We are aligning with federal CMS standards, make it a little bit easier. And currently, right now, we are in the design phase. Basically, the solution, since it is a COTS off-the-shelf solution, will be configured to make it more Kentucky oriented as we approach the business of Medicaid. And so the design sessions are supporting that pre-configuration effort. Prior to this phase, we were in a requirements validation phase. The contract, as you can imagine, had well over 5,000 requirements in it. So we spent many months at the end of last summer, going all the way up until the end of last year, 2023, validating requirements. And now basically what we're doing is making sure that we've got the design or communication in place to help configure the product. Our go live date is scheduled for early 2025. We will be on a quarter pure due to financials. I wish I could give you an exact date. There are some impacts to potentially the go live date. The existing legacy system has been experiencing many changes throughout as a custom design solution. And so we are currently targeting early 2025. The second to the last bullet from the bottom, very excited that just yesterday we stood up our MCAFS website, which is a page, part of the department, existing website for external public facing. And we do have our own page where we will post communications for the public and inform our providers, members, and trading partners, et cetera. So that is one tool that we're using. It's certainly not the only tool that we're using. We do have an internal SharePoint site. We've got minute newsletters that are coming out. So there's multiple tools, but we're really excited about this external facing website to the public to get everyone used to what's coming in 2025. We also have an email that you can contact. It is being manned, and Q&A answers anything you need to ask related to MCAFS. How is it going to impact me, my committee, et cetera? Please feel free to use that CHFS MCAFS project at ky.gov site. For those that have internal ky.gov access, there's also a master project calendar for formal meetings that are posted there that can be drag and dropped into your calendar as well. So we're really excited about that website as well as the email address. And once again, it's tools to just facilitate communication with all of our trading partners and stakeholders. There are several enhancements for the MCAFS solution that would like to point out. We've got automation of our workflow of existing manual processes for contract management, et cetera. There is going to be the ability for members and providers to view claims and or encounters online, which is a step in the right direction. There's document management, enterprise content management solution. There's going to be an MCO portal, program integrity case tracking, consumption of clinical data management, population health, TPL services for fee-for-service, as well as managed care members. And that's just a few of the enhancements that will be forthcoming with the new MCAFS system. I've got a diagram here that I wanted to present to you all to show you the components. It's a very complex system. The heart that you're seeing here in the center highlighted in blue is the View 360 user experience and what can be done there. It's basically the central user integration area that you would interact with and see all of the different screens or panels and interact with the system and its capabilities. There's many more modules that I won't go into here. Most certainly, we will share this PowerPoint presentation. I believe it's with Aaron that we will do so. But there are TPL, fraud capture. There are many things that the system has capabilities for. Letters, portal, as I previously mentioned, call center. And so this is a great diagram that you can take a look at and see possibly where different services or capabilities, functionality would live in what we're calling the MCAFS solution. I know that there probably are a lot of questions coming out. We are increasing our communication mechanisms, trying to get more information out. We've got work groups internally stood up. We also have organizational change management, change champions, different communication mechanisms, as I previously mentioned, to try to get the word out, because obviously with a change and a solution such as this, everyone wants to know, how is it going to impact me? Or maybe might have had some memories of the last change of the MMIS system in 2007. I do want to assure everyone, we are taking a look at our testing of the solution. We're in test planning right now, which will come after the configuration phase or design of the system, and want to make sure that we've got the scenarios, business rules, edits, audits tested appropriately so that there is no interruption of claims payment, that there is no impact to providers and their enrollment. So there's a lot of news, exciting things to come. And once again, we do have that email address that you're free to ask any questions, give us some suggestions on how we can improve communications, getting the word out, and want to thank you again for your time.
Thank you so much, Mr. Flagler. My first question is, how does this affect, and then you start, MCOs, providers, members, and we look forward to getting the PowerPoint so we can look through this a little bit more. Kent Gilbert is asking, when will your new website go live?
The external facing website went live yesterday. So
okay.
It is currently live. I did, before I presented here this morning, test it myself and can verify that you can get there.
And one gets there how? Through the DMS website?
Yeah, could you put the link in if you put the link, the link that was on the screen is not currently working, but if maybe there's a typo.
Mercy, okay. Well, I will definitely have that fixed, and I thought that we had added. I believe you can get there through DMS, the CHFS. Are you able to get there?
I can get to DMS, but I haven't been able to find it. I'm on the Medicaid Claims Administration and Financial Solutions current page. There's no obvious link to the new pages.
Well, I believe that is the link that you're looking at, the MCAFS.
Yeah.
That's it.
Okay. That's it. Okay.
Yeah, it was just launched yesterday, and it will be built out much further. So good.
Right. Good. Thank you.
Listen, after the blow up of Zoom links 2 weeks ago, I don't trust any of these links. So that's very helpful. I'm wondering if it would make some sense to have you back to talk to the MAC in November. As you're much closer to actually going live, and we can be in touch about this. We meet every other month, so September or November, it would be helpful to have an update from you at that point before you go live again.
Absolutely. We will support the committee in any way we can.
Okay, thank you very much. Let me see if there are any other questions from the MAC members. You've introduced us to a whole new alphabet soup here, Mr. Flagler. So we're gonna have to we know MMIS, so this will be different. Any other questions from MAC members?
This is Garth Bobrowski. I've got one. Of course, as you talk about billing for claims and things, it's just like one of the things that's happening recently is, I think it's with Change Health, what is it, ransomware? What security measures are you implementing or concerning links and stuff to help us be safe with our claims and a lot of offices getting paid in a timely manner?
Well, security is a big concern of ours. Of those 5,000 requirements, there are numerous security requirements that are mandated for the vendor. And, one of them, the minimal acceptable risk standards for exchanges. I can go through many, the NIST, standards. Those are all part of this. Third party security assessment is going to be required. Regular penetration testing, vulnerability scans are required. Those are all ingrained in the contract and is something that we are very sensitive to. And in fact, I'm glad you brought that up. I personally, of all the 60 plus meetings each week on this project, make certain that I attend the regular weekly security meeting. And so I'm very involved in that component, have done several MARZ security assessment reports for numerous states, and that is near and dear to my heart.
Yeah,
Thank you very
excellent,
much. Appreciate it.
excellent question, Garth. Because that ransomware attack has really disrupted billing for lots of providers. Obviously not just in Medicaid, but outside of that. Any other questions from MAC members? All right, well, thank you so much, Mr. Flagler, and we look forward to hearing an update. Appreciate your sharing all that information with us. Thank you.
Thank you, Doctor.
Dr. Schuster.
Yeah.
Hi, this is Dr. Wright. I had a question prior to Richard's presentation that was related to the TAC reports, and I apologize I didn't get a chance to ask the question sooner. I was meeting with someone here that has a new diagnosis of a child with Angelman syndrome in the northern Kentucky area. I am wanting to ask the team the process by which a child that has a critical chronic kind of disability would start the process of applying for Medicaid benefits in northern Kentucky, starting with home and community, then move, also adding themselves to waiting list, just to see if there's actually a flow chart or any type of infographic related to how that application process starts. I kind of gave them what I've known from past, but I want to just make sure I'm giving them some help moving them forward. So I'll wait to hear that answer. And but I just wanted to ask that question.
Well, it's so interesting that you're asking that question, Eric, because Commissioner Lee and I had just had a conversation on Monday as she heard from several parents with exactly those same questions. How do we negotiate this? We have a child who's diagnosed with whatever it is, autism spectrum disorder, actually a traumatic brain injury, and have felt like they were on their own trying to navigate the system. So I'm so glad that you brought that up. We talked actually, and we could certainly pull you into that discussion about how best to both educate these parents, but also get input from the parents, and whether it should start at the TAC level. It could start in behavioral health. It could start in children's health. It could start in the consumer TAC. Could start at the IDD TAC for that matter. And what's the best way to get this input from the members who are really struggling? And then, what should our response be? So we're just at the beginning stages of this. And your very notion about a flow chart, I think, is something that actually one of the moms had suggested to Commissioner Lee, and I'm supposed to talk with that mom sometime this week to get, more of a feel for the story and what she's been through. But we absolutely need to be providing clearer guidelines and more usable information for people who need to get first the Medicaid coverage and then negotiate the various waivers and the waiting lists. And then with the possibility of a new children's waiver in the second year of the biennium, there's funding in that to continue that study and development for kids with autism spectrum or severe emotional disturbance or chronic health conditions. So certainly the youngster that you spoke about would be covered in that as well. So I don't have an immediate answer for you, but I will tell you that it's on the table. And that we're happy to include you in those discussions as we try to figure out the best way to get information from those families and then get information, the best information back to those families. Commissioner, do you want to add anything to that?
No, I think Pam has her hand up. We'll see.
Oh,
Yeah, she
okay,
probably
great.
has something to add. So Pam.
We actually do have a flow, kind of a flow chart, a couple little guides. We actually, Alicia and I just met with some case managers with a group with the U.S. Army that handles military families that have children or other family members with complex needs, and we handed a bunch of them out yesterday. So I will get the link and have to Kelly or Aaron to send out to the TAC members. It's on the website, but we do have a couple resources, a who to call list, and flow charts about, this is where you start, this is the next step, this is what to expect next.
Right.
And I think there's one other, there's 2 or 3 things that I think may be helpful. So I'll get that link to Kelly and Aaron so that we can get it sent out.
Thank you. You're fading out a little bit, Pam, but I think you said you would get those links to.
Yes.
Yeah,
Yes.
Kelly and Aaron to get out. That would be very helpful. And certainly in this immediate situation or with these moms I'm going to be talking to, we'll get that out to them.
And also too, I would add that when you get to the point of, that the waiver application is entered, it is a no wrong door application. So we look at, every application that comes in, we look at every waiver. We look at all of the needs presented on the application, and we can forward them to, for example, if they would meet the criteria for both the Michelle P and the SCL, we can forward them to both of those, all within the same application.
That was going to be another question I was getting ready to ask. So I guess, Pam, in Northern Kentucky, is it North Key or is it the Point?
You have both. You have, there's a couple areas. So the Point helps, North Key helps, and then the Northern Kentucky ad also can help do those applications. So there's several areas in several groups in that area that are able to facilitate that application to get that entered. And we also have the guide that for individuals, if they want to, they can create their own account on Connect, and they can actually do the application themselves too. Sometimes people find it a little more complicated or a little difficult, so it's easier to go through one of those entities to help them to have answer questions. But we do have that resource that our eligibility team was so nice to share with us, that we take and hand out when we do those 2. So we'll make sure that also is part of that link, so that they have multiple resources there that they can reference.
Thank you very much.
You're welcome.
And I'd just like to add, Dr. Schuster, I think your recommendation or your suggestion that, we let some of the other TACs look at that flow chart, because if it is or that diagram, if it is on our website, maybe it's not easy for some individuals to access. So how do we make it more accessible, and is it user friendly? So I think letting the TACs that look at that would help us maybe ensure that it's an easy to follow diagram and points people in the right direction.
And easy to find to begin with is the other issue, if people don't know where to go to find it. So yeah, I think that's a great place for us to start. So appreciate your bringing up this issue, Eric, and it really fits in with some discussions that we're having now. So we're happy to loop you into those discussions as we move forward. Thank you.
Thank you, Dr. Schuster.
Sure. Last item on our agenda is the language access issues. What questions do we have? What data do we need from the MCOs? We want to have a presentation in May on this, very, very specific, not a broad, here's what the MCO is doing. So what are some of the questions that I want to get with Emily Beauregard from the Consumer Rights TAC, because obviously they have been delving into this and talking about different populations. So And I see, Dr. Gupta, that you're putting some questions in the chat, which is very helpful. What questions do other Medicaid or MAC members have about language access? And how much of a problem is it, I guess, is the other thing. It's always been an issue in behavioral health.
This is Peggy Rowart. Can you hear me?
Yes, Peggy.
I'm sorry, I was at the meeting. My phone has been having some problems. So I recently have had problems getting access to answers so I can understand everybody's frustrations. With getting on the cell phone to look at healthy rewards and going on a website is two different things. And I'm getting mixed messages about the healthy rewards, about they are not giving out the gift cards to Walmart, and now they have these points that you go on the website to look at. Also signing up for Weight Watchers, having problems getting signed up with that. The doctor, it's kind of like a merry-go-round. One says this, one says that. So as a Medicaid recipient and other people, and I have some computer skills, so I could imagine how everyone else is having a hard time to access when it comes to behavioral health or physical health or anything.
Yeah, so it sounds, Peggy, like you're sharing with us some concerns, frustrations that you have as a Medicaid member about accessing some of the services like the healthy rewards or following through, for instance, on signing up for Weight Watchers. And is part of the problem not knowing where to get an answer to that or to get any help with that?
I'm having, like when I call in, I'm getting different answers, and it's like nobody knows. So I feel like everybody needs to be trained properly. Everybody needs to be on the same page and not be just saying one thing and then doing another. And then you're left in limbo. So I can understand people in rural areas and they're trying to get help because I'm having problems myself.
Well, that's very helpful information to have. And it sounds like when you call, you get one set of responses. And if you go online, it looks like the information is somewhat different. Did I hear you say that?
Yes, and also if you call back and you get a different person to speak to, it's completely different.
You get a different response.
Yes.
Commissioner, I don't know. I'm sure that there's regular training for the call center people.
Yes, there is. And Angie Parker, I think, has something to contribute to this. Angie?
I was going to comment regarding language access, because we are working on information to share and provide to providers. This has been a request for from the disparity TAC and the consumer TAC, and we hope to have something for that in the middle of May to share for review. But as far as what Peggy is talking about, I'm not sure which MCO she is working with, but are you calling your MCO specifically?
Yes.
And you're getting different answers in the member services line? Is that what I'm hearing?
Yes.
Hey, Peggy, this is Erin Biggers. Quick question. Are you continuing to still have issues after our most recent outreach?
Yes, I am.
Okay. If you would like to email me offline, I can send that back off to their last response and we can work on that for you.
Okay, I appreciate that.
That's great, Erin, but I guess I'm wondering if Peggy happens to be on the MAC and so has the advantage of having your assistance. I just want to be sure that we're looking at that issue at a broader level, which was leading me to the question about training. And I guess I was thinking more of the call center, but it really is the customer service for each of the MCOs is the other place.
Yeah, we can definitely reach out to the MCO. Well, first of all, I guess we could get online just as Peggy did and see if we have issues on this end and see what we can find related to issues trying to access those services, but definitely we'll discuss with the managed care organizations to make sure that all of those value added benefits are easily accessible and that their members know how to access those value add. And if they have to go online to get it, and as Peggy mentioned, there may be some issues with individuals who don't have access to go online. So how are they informing their members that they can access those benefits?
Exactly. That would be really helpful, Commissioner, and I may put that as a follow-up in May.
Okay.
For you to, or Angie or somebody from DMS to let us know, what kind of response. Because I do worry about the number of people that don't either have internet access, don't have access to a computer, don't have those skills. And so if they're relying on their phone, it's so important that the people answering the phone have the same information to give them.
And maybe if we don't have a report, maybe let's get a report from the MCOs telling us how many individuals are accessing those value add benefits.
Yes, that would be great.
I'm all about the data.
Yes, I know you are. That's a good question. So let's put that issue on our May meeting as well. Angie, thank you very much, Peggy, for bringing those issues up. I think that's really important, and it's why we have consumers such as yourself on the MAC. So really, really appreciate that. Angie, I want to come back to this report that you're talking about that I guess was requested by the disparity TAC and also the consumer TAC.
Right. We have the information from each of the MCOs. We had gathered that a couple of months ago on what they do regarding language access. And so we're working with our the Medicaid internal communications team to develop a member and provider language access communications piece. Obviously, we'll have the tax look at that to see whether or not it meets their expectation or will be helpful, but that is in the works.
Okay. Could I ask you to look at the questions that Dr. Gupta has put in the chat specific to that to see whether those items would also be included in your report?
Easy to access. Can providers use it readily in the exam room with the patient, or is there a long wait? We will certainly take those questions back to make sure that to see whether or not what we were working on addresses those specific questions.
That would be great. Would you all then be prepared to share that same information at our May MAC meeting, which would be at the end of May?
If it possibly, we're looking at mid-May to have it ready for review. Hopefully it will be, and if it is, by then we will certainly share it.
Okay. All right. Let me do this then and ask any of the other MAC members if you have some other questions as you kind of think about this, or if you think about your discussions, if your TAC has talked about this, and I'll send this out to the TAC chairs as well to send those additional questions to me so I can get them to Angie. That would be very, very helpful. Thank you very much, Angie. Are there any items of new business to come before the MAC?
Dr. Schuster, this is Garth. I want to go back one step if you don't mind. I had a question on because we were having a staff meeting yesterday afternoon, and the topic came up then of even our seniors in our rural towns and accessing services or value added benefit, either one. A lot of our seniors just do not have very good computer skills. Mine's even lacking, but I try to learn on all this. But the seniors with limited computer skills, and I think that's partly where the commissioner is working on our community health workers. I know sometimes our local libraries will have computers set up for free access. And I know sometimes our local health departments, but sometimes I just worry about these folks that sitting at home. It's like this, they just think I don't have anybody to help me. And I think that's maybe something to look at, because some folks, they're just totally lost in the computer world. And I know in about 10 to 15 years, that'll probably fix itself. But I just worry about the folks now that have issues getting access or getting information.
It's an excellent point, Garth, and it's an interesting way to think about language access, because if you can't use the modality, so to speak.
Right.
Dr. Gupta had some questions about people that were hearing impaired as well as having a language issue or visually impaired. But in some ways, not having those computer skills is almost like speaking in a foreign language. I wonder if that is an appropriate way to use CHWs. I know the peer support people often will be helpful for those with behavioral health issues, because it's a way to access services as well as benefits and so forth. So something else that we ought to keep in mind, but I appreciate your bringing that up. Navigators, connectors sometimes are kind of become an ongoing resource for people because they got connected to Medicaid and so forth with a connector, and they become kind of a reliable source for help as well, but navigators as well. So something for us to keep in mind for sure. Appreciate that. Any other items of new business?
And Dr. Schuster,
yes.
Justin has his hand raised.
I'm sorry, I didn't hear that.
Justin Derringer has his hand raised.
Oh, okay, thank you. Justin?
Yes, I just wanted to say that community health workers are able to provide those type of services, those one-on-one services to individuals to help them gain access to care, to coordinate their care better. That's part of their job, is to work with each individual person, to be able to also reach out to different interpreter services that Medicaid contracts with. Also want to remind everybody that the Department for Community-Based Services also still has in-person services available during certain hours in most communities. So people can always go to their office and meet with someone one-on-one, and they also have access to different interpreter services there at their office.
Excellent. Thank you very much. I did wonder about the CHWs, and that makes a lot of sense. But I had not remembered about DCBS, and since they're open for business, at least in some limited hours each day, people can go in without an appointment even and get some help there as well. So maybe part of our finding your way into the system, which is what we talked about with Dr. Wright's case and Pam's response, but let's be sure that our helpers, that we have some kind of available list of helpful agencies or classes of people that are helpful, so that people are reminded of that, and for providers to be reminded as well. But thank you, Justin. That's very helpful. Any other comments on that, or any other items for new business? Seeing none, I'm giving you all back almost 40 minutes of your day. This is an all-time quick back meeting, although I think we had some excellent discussion and lots of materials that we will follow up on. But if there is no further business to come before the MAC, we'll just adjourn by acclamation, as they say.
Structures that are in place.
I'm sorry, was that a comment for all of us, or? All right, well, we will adjourn the meeting by acclamation. I assume there are no objections to that. And have a vote by leave taking, yes. And for those of you who celebrate Easter, a very happy, or as I say to my grandkids, a very hoppy, Hoppy, Easter to you all. And a reminder from Marcy Timmerman that Mental Health Month is May. And we'll be talking about that at our MAC meeting as well. Thank you all very much for your input. Appreciate it, and have a great day. Bye-bye.